Good evening, I'm Joe Mills, I'm Director of Strategy at Royal Surrey County Hospital, and whilst Matthew is the Chief Executive Representative to the IHT Programme Board, I am the Director of Strategy Representative to the same board.
Charlotte Keeble, Senior Programme Manager for Improving Healthcare Together.
Thank you very much for that. So I think I'd like to ask Andrew if you would present your report. Thank you.
Thank you. So I agreed to do a verbal update of where we are with the programme. I think we are at a stage in the programme where, as the committee members know, we have submitted an update to our draft pre-consultation business case, which went up to NHS regulators earlier on this week. And alongside that, we also published a stakeholder briefing that summarised our thinking and the evidence review work that we've done to date in looking at the options that we've been considering as a programme. And we put that out into the public domain because we thought it was important to set out our thinking in terms of the appraisal of those options to date. And whilst it's still at a point in the programme's journey where we will not confirm a preferred option until we've gone through a national assurance process, which is required of us. And of course we are open to considering any new evidence or issues as we proceed. We wanted to give the public a clear indication of our direction of travel, and I think importantly the sort of strengths and weaknesses really of each of the options as we've considered the evidence to date through the programme board. A couple of things just to, I think, mention around that. We're not able at this stage to publish the full pre-consultation business case. That's still in draft form, and neither have we published the financial modelling work that we've done to date, and we've done that explicitly because that could change through the regulator review, both in terms of the pre-consultation business case and also the work that we've done around our financial appraisal. But we have always made a commitment to publishing what will be the final pre-consultation business case after national assurance and immediately before and if we proceed to consultation, which is still our intention, where we would set out a preferred option and also the other options I think that we would want the public and all stakeholders to consider. So I guess an important stage in the process, but it's still a stage, and we will continue to engage on the material that we've published, and hopefully people will see the stakeholder briefing as a clear articulation of where we've got to date. So that's my summary. And whilst I know that the main purpose of this committee in drawing together the full JOSC for both South West London and Surrey is around the provider impact work, which, and hence we've invited Matthew and Joe to be with us this evening. It does include a brief explanation of where we've got to with that provider impact work in the stakeholder briefing summary, and that's all I wanted to say this evening.
Thank you, Andrew. I think at this stage I'd like to also perhaps bring in Councillor Steers, so he just wants to do a brief update from the subcommittee perspective, and then perhaps if it's just to keep the flow, maybe if there are any burning questions, otherwise we can wait for the main report presentation and have asked questions afterwards. But if I can just let Councillor Steers do a brief.
I'm quite happy for Councillor McCabe to come in as well.
Councillor McCabe,
Okay, thank you very much, Chair. We've had 5 meetings of the subgroup. I must say that we have had some information that we have been happy with. We have had concerns about some of the governance arrangements and how people have been chosen to sit on committees, the stakeholder groups, etc. We were concerned about confidentiality agreements, which was placed in the public domain at the last meeting. And I suppose we needed to be assured that when we had our initial meetings, we pushed back a bit as a subcommittee and said, we think you should do more, we think you should do more. We hear that you've done more and you take into account changing circumstances. It's not always evidenced, and we get that reassurance every time. So I think what we're looking for is a bit more evidence around how you're taking into account the changes. And for instance, we've got the activity on 1718 for the St Helier Trust. I think we would like to see what's the latest information you could give us on activity? Are those percentages changing? The provider impact assessment is very much around the local hospitals. And I think the colleagues around the table want to drive that down into their communities. So we would like to see what sort of activity, up-to-date data for that activity, so that colleagues around the table can understand what that balance their communities with the buildings and the bricks and mortar, which is actually what the provider impact assessment appears to lay out. We also need it because we want to make certain that any scrutiny of a mandatory, a formal consultation has the right reference group from councillors in terms of the communities across South West London. So that's why we'd like some as much in up-to-date information as we can regarding activity at the Trust, has it changed, movements, etc., etc. So I think 1718, I think you probably have this information reasonably to hand. So we would like to see that. We would then take a view on how the committee could be structured. I think the feeling is that we would expand the subgroup into South West London, other boroughs that might be affected. I think we've just had a discussion and we feel that's right and proper from a resident's point of view, that we represent the residents of our wards, our boroughs, etc., and the whole community as we're moving towards a South West London CCG. There's a lot of work to do. We are anxious to see the business case as soon as possible. That will then colour how we can move forward as a scrutiny committee when it moves into the mandatory stage. Councillor McKay, would you like to come in there?
If I may, Chair.
Apologies, yes please, Councillor McKay.
I have from the outset expressed concerns of my local residents that there is an inevitability about the outcome of this whole process. And I have to say, as the whole thing has gone on, the views of local residents who attended one of the stakeholder meetings that I was present at, and a pretty stormy one at that, have I think proved well-founded. I've just heard our colleagues somehow talking about being transparent and open, and yet, one of the things that I have found really irritating about this process is the occasions where papers arrive so late that there is little or no opportunity to properly scrutinise them, and it feels as though people are wanting to keep things from elected members who represent our local community and not give the opportunity for proper scrutiny. So I think there have to be some significant changes to this process if it's to have any value going forward. There is an issue of credibility, and I think every time something like that happens, and when we have the kind of discussion that we had at the last subcommittee meeting, when we had non-disclosure agreements in our hands and we've been told that they weren't non-disclosure agreements, that too undermines the credibility of those that are driving this forward. And I really do think the time has come, if we're going to work together in partnership, as we should, then people need to listen to the views of local representatives who represent the local community.
Thank you, Councillor McCabe. I think I'm just drawing on some of the points that have been mentioned. Councillor Fitzsimons.
Thank you. I'm very interested to make certain that the health people are in line with the legislation regarding consultation with the public and with this committee. And one of the regulations I understand is that you're supposed to provide us with a timescale. Okay. I'm just reading some of the guidance from some regulation now required timescales to be provided to health scrutiny bodies and to be published by the proposal of substantial developments or variations. Regulation 23. How are you going to meet that?
So we're not actually yet in consultation, and so in what respect? The timescales for the consultation, or
Because I think we're supposed to be told about it before, right?
you will be. So you will be when we know ourselves. And one of the things that we have to do, so the national process now, is that the regulators will look at the evidence that we've provided to them, and they'll give us feedback. Then what we will then do is we will then provide you with information on when we will make a recommendation as CCGs about going out to consultation. So we'll do that in public, and we'll have a decision as to whether or not we've got a preferred option or not, and you will know about that. And then we will set out when we will go to consultation, how long that consultation will be, and we will let you, as soon as we know from the regulators that we're in a position to do that process and to go forwards, then you will know. You've got to remember that we're not yet ready for that process, so we are just in the engagement phase at the moment. We're still gathering evidence. We haven't actually got to the point of making a decision about going out to consultation.
I'm not asking about whether you're in a position to go out to consultation. I'm trying to understand how you're going to make certain that we as a committee are told beforehand, right, far enough to advance, because having done this in the past for the similar ones, we were able to comment before things were set in stone, because otherwise we end up us chasing your tails when you need to be coming to us much earlier and saying we'll likely be going out in the new year, we'll be speaking to you in November time, right? Because I imagine that you do roughly know when you're likely to go out. You're not likely to be going out in 5 years' time. You're not going to go out tomorrow, but sometime within the next year or so, you're likely to go out. So my assumption is that it would be good if you could give us some indication about how this committee would be given enough warning so that we are able to say whether those consultation processes are actually meet the requirements.
So we think we'll be able to come to you in September to talk to you about the consultation process. What we won't be able to tell you at that point is when are we going to consultation, because it's a national, we are reliant on the regulators. It's a different process to previously because we're waiting for them to tell us. We think that we will be able to come to you in September and say this is the process we intend to use around consultation. Then as soon as we have a response from the national regulators that says we think we will tell you immediately that we've had that, and we will set out a timetable for us to do the decision making, publish all of the documentation, and do the consultation. So you'll have the plan around how we intend to consult before we have the details on the date. Does that make sense?
So, because we need to set dates in our diaries, right, and availability, are you then suggesting that's a recommendation to us that as a committee we should be setting a date for ourselves in September?
So if the committee is going to expand, which I think is what it heard through you, Chair, so we've been continuing to have a dialogue with the subcommittee about the potential timelines around the consultation, and we've been very careful about not being able to give a firm date as it stands. We've taken through to date the discussions around setting a small subgroup, a reference group of sorts, to help shape the plans around consultation. And the intention has always been, and I think this is minuted at the subcommittee, that we would bring the consultation plan to a future date. September seems to be the right time to do that, but we could then have a large gap between setting out the consultation plan and physically then enacting that consultation plan, because we are subject to getting national sign-off and a clear signal in order to do it. And of course, in answer to your point, we'd be very, very keen to get thoughts on how best we can do that. We're continuing to take advice from bodies like the Consultation Institute on what is best practice around that consultation. And the other factor which I think is really relevant is the longer we leave it in terms of having that dialogue, the more difficult I think it becomes to continue to have a debate with people. So we want to be as open and honest with this committee and with the public about the arguments that we set out. That's why we've released the stakeholder briefing, because there could be some time between publishing our early thoughts and then publishing a final consultation document. But if we get a green light earlier, then of course we'll seek some support from the committee to try and get that through as quickly as possible. Because I think it's in the public interest to do that.
Yeah, I suppose it's a little bit concerning that when you say we don't know, you have no indication of times from your colleagues at a regulatory level?
So we are relying on all sorts of national processes, and some of that is political as well, to be honest. So we are awaiting, number one, the regulatory process where they'll check the work that we've done and they'll give us feedback and we may need to change things. But then there is, we are required to wait for a letter. This is new. This is, this is a new process. It's not how it worked in the past. In the past, systems would go out when they were ready. Now we have to wait for a letter that comes from the national regulators to say that we are allowed to go to consultation, and they do that not just on the basis of our business case being ready, but also on the ability of us to gain capital. And there are lots of ifs and buts around whether or not we will get capital, including things like possibly the spending review, national politics, Brexit, all sorts of things that will impact on their decision about whether or not they think that we have a good chance of getting capital. So we can be ready as a system to go, and we can tell you we are ready to go, and we can give you the consultation documentation and all of that, but we won't actually, until we get a letter from the national team saying you can now consult, we can't consult. So that's our position. So we would like to come to you September, whenever it's convenient for you to come and talk about the process of the consultation, and then as soon as we have an indication from the national team, we will come and talk to you. So as soon as we have that letter, we will come and talk to you and say, we've now been told we can go or not, or whatever it is they are saying, and this is how we'd like to proceed, and then we will be able to give you a very clear timescale. But even when we get the letter to proceed, there is a formal process for the CCGs to go through to make a formal decision to consult, and whether or not they have a preferred option. So we will need to go through that before we even go to consultation. So there will be a gap between getting the letter, us making the decision, which will need to be in public, and then going to consult. So we should be able to give you a level of warning that those timescales are coming. At the moment, it could be that they go through the process and they say September, you're fine. They could say we're going to wait for the spending review. If anyone knows when the spending review is going to be, I'm happy to receive that information. So it could be we wait for the spending review. They could say we have to wait until we've got full Brexit finished and we've got all these other things, and if anyone could tell me when that would be, I would also be very happy to receive that information. So we are a little bit held by some of the politics around this and where we are in the process.
Thank you, Sarah. I think Councillor Critchard just wanted to ask a question.
Yes. The first thing that struck me is you said that there's been a stakeholder bulletin published this week. I don't know if I missed it or if it didn't. Well, I was just saying.
No, I just found it, yeah.
Yeah, but what I was going to say is one of the things that I'm listening to colleagues would worries me a bit is that if we're on the joint OSC and we haven't had notice of a stakeholder bulletin, I understand obviously we've got a subgroup, I just put that out there in terms of keeping us involved and engaged. And the second thing is on this national assurance process, are there any questions in this process about how you've engaged with your local councillors? Because again, it's the councillors on the subcommittee will be able to indicate whether they felt sufficiently engaged, and hearing what they have to hear, what they're saying tonight, makes me question, has that process been gone through enough? Even if it's, done more privately, we as councillors, sometimes there are discussions that we have that we know that people have private discussions, or they share things with us that aren't necessarily ready to go in the public domain. I think that's fair. We understand that process. But that's the bit I'm wondering about, is if you're going for a national insurance process that will ask you how have you been engaged, and then somebody goes, well, hang on a minute, we're not sure it sounds like colleagues don't feel they've been engaged as well as they could have been. where does that leave you in the national assurance process? Sorry, I was a bit long. That fair comment.
Thank you, Councillor Pritchard. I don't want to be able to answer that, Andrew.
So we've tried to be as full as possible. I think in terms of sharing information, both through the engagement work that we've done. The programme has been running for now just over 18 months, and I think we've run. I think we've done two things. One is run as comprehensive, I think, an engagement programme at all. We've not been in consultation, but we've been trying to reach out across all the combined geographies of the 3 CCGs. And we've published, in fact, all of the work that we've done in terms of that engagement. I also think we've responded, I think, to concerns in relation to the recent discussion we had at the subcommittee around the integrated impact assessment, where there was, I think Councillor McCabe asked whether we consider running some additional focus groups as part of that assessment. That work will be ongoing, so it's not that it's fixed at a point in time. We have to publish all of the engagement reports that we've done, summarising each of the group discussions that we've had, all the activities that we've done where we've reached out to each of the communities, and I think we've done a lot of that. Obviously the CCGs have done a lot of engagement themselves, and all of that evidence has to go alongside the pre-consultation business case, and that's then tested by a national oversight committee that says whether or not we have considered as far as possible all of that engagement. So I think we'll continue to try and share information as early as possible. Sometimes the timing of being able to supply papers to the subcommittee doesn't work, but that's because we're dealing with I think quite a fast-paced environment, and sometimes it can't be completely aligned.
Thank you, Andrew. I think Councillor McCabe would just like to ask a question. Thank you.
Well, it's not a question, it's just to enlighten other members of this committee. The reason that I asked that particular exercise be undertaken is that we were hearing that there have been groups involved in deprived communities who have been consulted about a proposal that certainly has an impact on Pecuniary Hospital in Morden. And the two deprived communities were Rains Park, and the people from that part of the borough are not deprived, generally speaking, but they would gravitate towards Kingston as their nearest hospital, and the other deprived community was Colliers Wood. Now, Colliers Wood is just up the road from St George's, so if you're asking people questions about something that affects them at the hospital, and you get about as far away in Merton as you can, and you're supposed to be consulting with deprived communities. I don't know if you've looked at house prices in Colliers Wood. There are pockets of deprivation there, but this is on the northern line where the gentrification is spreading ever further. And frankly, to have to tell our colleagues from health that that's not necessarily a representative way of setting about this is a bit shocking, to be perfectly honest, and I think most members around this table would agree that that would alarm them if they heard such things were going on. And I'm grateful that they did take up my suggestion that they should talk to people a bit closer to St Helier in areas of deprivation, in fact including my own ward. But I have to say that the numbers involved in that exercise were very low indeed, and I still question, how they arrive at these sort of representative groups, because I'm not entirely convinced that the methodology is sound, and what they'll say in response is, well, we appoint consultants who know what they're doing and you shouldn't be questioning them. And if they know what they're doing, then what are they doing in Rains Park and in Colliers Wood?
Thank you, Councillor McCabe. I don't know if Andrew, if you would want to comment on that at this stage.
So I've nothing further to add. We did run through, I think, and have dialogue around subcommittees, and our intention to address those elements.
Thank you. Are there any questions from members? Councillor Steers?
Yes, I wonder if we could have just a bit more detail about that, how the provider impact assessment was set out. We've seen a one or two pager that we had at the last meeting, and I think colleagues might want to just get Matthew maybe to put a bit of meat on the bone on that one.
I think perhaps if you're agreeable, Councillor Steers, that we could take your question that you just asked after the main report. Would that be a better point for that to be answered? I think that might help.
I did have one other query. We mentioned about time delays, etc., and we are aware of the reconfiguration of CCG, shall we say, in South West London. Could that have an effect on timelines, etc.? Are you happy that the governance arrangements are there, that any change in the way that the CCGs will work and will function won't affect anything?
So the statutory responsibilities are the same regardless of the configuration of CCGs. They're doing something similar in Surrey as well. My expectation is that whenever the decision needs to be made, a CCG or CCGs will be able to make that, and it will not make any difference. It could be that it's a different geography of a CCG, but it's still the statutory function of a CCG. So it'll happen whatever it should be, the impact is making.
I think just wanted a bit of assurance and reassurance that the journey, that it will be seamless, because at the moment we've got 3 CCGs working together on this, and we won't have possibly in the timeline. So
what I would say is we already work really closely together in South West London anyway, so we will seamlessly move into the new structures should they be approved by our membership, and we would be able to make a decision even in the configuration that we currently have or any future configuration, not making a difference.
Thank you. Thanks, Councillor Steers. I think what I'd like to do is move on to item 6, and then I think once we've had that main item, impact on other providers, there'll be an opportunity to ask further questions at that stage. So if I can hand over to you for that, for item 6. Thank you.
Thank you, Councillor. As I said earlier, I'm the provider representative on the IHT programme board, and what that entails is working with the 6 impacted acute providers, and for absence down for clarification, that means in the London patch, Kingston Hospital, St George's Hospital, and the hospital as part of the trust that I run at Croydon. And then in Surrey, it's East Surrey Hospital in Red Hill, it's Ashford and St Peter's Hospital, and it's the Royal Surrey County Hospital in Guildford. So those are the 6 providers impacted, and my role has been to represent them on the programme board, and indeed to help support them in the completion of the provider impact work, which is summarised in the document that colleagues have this evening, and that we went through with councillor colleagues at the subcommittee last time round. But I'm happy to set out a few of the headlines, if that would be helpful, just to put a bit of flesh on the bones, and then happy to take any questions at all about that particular part of the process. So the provider impact work has been led by 2 key groups really, a technical group of strategy, estates and finance colleagues, and a clinical group which has had nurse directors and medical directors from those trusts involved, talking about essentially one question, which is, depending upon where the major acute site is located through this programme, whatever is recommended and finally agreed, what impact does that have on the financial, but not only that, but also issues such as staffing and overall deliverability on those 6 other providers? Because obviously, depending upon where that major acute site is, will make some changes to the flows of patients. Now, this is obviously a judgment, because until you actually make a change, you can't be 100% sure, but there is a well-developed methodology that's been used in other processes such as this, which looks at the likely impacts based on travel time and various other factors, and comes up with an assessment of the variety, the various impacts on those 6 providers. So in essence, we've got 6 providers looking at those three options, and the technical group and the clinical group has helped to develop that process. And what individual boards, myself at Croydon included, has done is take that work that has been done and then reviewed it from its own provider perspective. So in Croydon, I can give that as an example because I did it at my board, we looked at what would happen if the major acute site was at Epsom, if the major acute site was at St Helier, or if the major acute site was at Sutton, and against those three options we said, is there a high, medium or low impact? And we made a judgment based upon the work that had been done by the technical group and the clinical group, and as a board, which is our responsibility in these matters, we made a judgment about what that impact would be. And further to that judgment, we also then calculated what we thought the costs and the impacts of that would be per each item. And as a result of that, we have come up as individually 6 providers with a set of judgments that you can see in the paper have then been summarised into the overall view of the providers in South West London and Surrey to the 3 potential options for the major acute site for the Epsom St Helier service. Now, that's a bit of process. In terms of what that has demonstrated, well, the first and really important message is for all of the 6 providers, we have said individually and therefore as a collective that all of the options from our perspective are deliverable. So there's no option that we would say is impossible for us to manage. That is not the same as saying all of the options are equally deliverable, but they are all deliverable. And that's an important message because it does mean that there's nothing that from a other 6 providers perspective that we would say should stop being worked on because it just can't work from the wider health service perspective. So that's one key message. The second key message is obviously, however, the impact is different depending upon where you are based and where the major acute site ends up. So if you are a London provider, say particularly Croydon and St George's, the impact on you is much more significant if the major acute site goes to Epsom. And the reason for that is, very straightforwardly, if the major acute site goes to Epsom, it is likely that some of the patients who currently go to St Helier won't go to Epsom, but they will travel to St George's or Croydon as their nearest major acute service, either under their own steam or via the ambulance. And the flip side is true if you're a Surrey provider. So if you're a Surrey provider, the biggest impact is if the major acute site is based at St Helier, because in those circumstances, some of the patients who would ordinarily have gone to Epsom won't go to St Helier, they will go to Surrey providers instead. If the site is at Sutton, then the movements are less marked and therefore the impact on the individual providers is less. It's not nothing, but it is less. And that's, in the simplest terms, what the analysis for the provider impact work has shown. Now we have finally, and my last point would be to say we have looked at a whole range of impacts. One of the key ones, but by no means the only one, is the financial cost. And one of the big elements of that is the capital cost. So if there's a development at either Epsom or St Helier or Sutton for the major acute site, then there are costs to be added to the development on those sites for the other providers. And you can see in the briefing that we've done that the most expensive in capital terms is for the major acute to be at Epsom. The second is St Helier and the third is Sutton. And that ranges from £174 million to £39 million. They are calculated figures based upon a judgment from each provider about what extra capitalist requirements would be needed on each site, so the development of further buildings and services on those sites, but it is only to do with the impact of this programme. That's not the total capital ask for those providers over this period. So in my own organisation, we have other requests into the system for capital investment. That's not in these numbers. This is just to do with the impact from the changes proposed between Epsom and St Helier and the impact that will have on the other providers. That's important for colleagues to be aware of. So that's, I hope, hopefully helpful and clear in terms of the process that we've gone through, why we've done it, and the broad outcomes. Happy to take any questions, and Joe, who's been a key part of this work, can assist in that, as obviously other colleagues can as well, but hopefully helpful.
Thank you very much indeed, Mr. Kershaw. And can I ask then members if they have any questions or they like to indicate at this stage? Yes, Councillor Stanley.
Thank you for your presentation, Matthew. In the previous report, and unfortunately I can't get online, so I can't put it up, we had an impact assessment and it had bed numbers on it. With the Epsom option, I think I can't remember the figure. There was a significant figure for Croydon University Hospital. So I'm quite surprised to see in this report you say all options are feasible, because when you looked at I remember looking at those bed numbers and thinking, well, that's just not feasible on the Croydon University Hospital site. So sorry I can't get the old figures up, but I'm interested that you still feel that all options are feasible.
Thank you, Andy. And so the short answer is, through the process, we have looked at it and we do believe that they are all deliverable. Clearly the Epsom option for Croydon has the biggest impact. That would require us, to develop a new set of facilities, not an existing, just to squeeze things in a little bit more, reduce the length of stay and everything will be fine. We would have to create new capacity on site. On the CUH site. When we say it is deliverable, it is, because we could do that. That would be challenging, of course. It would take a significant capital sum to build the building. Secondly, it would require staff to support that. And thirdly, it would take time to get that done. But it would be inaccurate to say it couldn't be done. If that was felt to be the best option, in the broad round, considering all factors, then the impact on Croydon would be significant, but it would be deliverable over a period of time. And that's why we said all options. But is that the same as saying all options are equal? Then clearly not.
What did you take into account in terms of, because you planning permission? Because I'm just thinking of that site. The only way you could expand, I think, is build up. So, was planning permission and things like that taken into account?
So we have estates, our estates team have looked at it. Have they spoken to the council and said, if we did this, could you give us planning permission explicitly for X? Then the short answer to that is no. We would obviously need to have that as part of the final piece of work on this. But is it technically possible for us to find the space by moving other things on site and making it work? And clearly, we can't go across very much at the CUH site, so it would require a build up. There is opportunities for us to do that, because not all of our space is the most efficiently used at this moment. It could be done. Would it be straightforward? It would not. But that's not the same as saying it is undeliverable.
Any other questions? Yes, Councillor Fitzsimons.
I'm just looking for clarity about this whole issue for me. And part of the reason, because I was just trying to look through some other papers, and I came across a press release from Sutton Council on the 29th of July. And welcome plans to keep health services St Helier and provide a new hospital in the borough. And it sort of welcomes Epsom and St Helier submitting plans to NHS to retain the majority of the services and build a new hospital in the borough for emergency cases and most at-risk patients. How does that fit into this?
So I can't speak for, I don't know if you can speak for Sutton Council, Councillor processes, but I can't speak for Sutton Council. We have made no decision around a preferred option, and we have set out all of our workings, and we have set out the ranking, and that's in the public domain that we currently have, but we may change that, because if we get further feedback and the finances change or something changes, then the CCGs have not yet made any decision around preferred option or going to consultation. So I can't speak on behalf of Sutton Hospital, Sutton Council.
I'm not asking about Sutton, I'm going to ask Matthew as the provider as well, because it says that the plan for it to retain, it says that St Helier submitted, Epsom St Helier submitted a business plan to NHS England.
So the council saying this, or is
This is a Sutton press release from Monday.
Sutton Council saying it? Yes, but
I'm the Scrutiny Chair, so I don't
so can I
get
just say
involved with
the
the policy stuff, which is...
as far as I'm aware, the hospital have not submitted anything. We have, the CCGs, have submitted a draft PCVC of which we have not made a decision yet. So I don't know what Sutton Council, where they've got their information from, but and you are Epsom St Helier Hospital. Have you submitted anything?
No.
No.
So is it possible for you then to formally let someone know? Formally, because you're not... Scrutiny councils don't act on behalf of their executive.
No. So I have no idea they've done that, and I'm happy to let them know that that is not the case.
Okay.
Thank you. Chair, I'd like to know, on page 11, there's this table that looks at the company associated with each project. Who's produced these figures?
So that's been produced by estates and finance colleagues in each individual trust, and overseen by the boards of those organisations, and therefore submitted to the programme as our, at this point, and that's important clarification, at this point, our expected view on the capital costs if the various options were chosen. So it's a combination of the individual providers saying it would, we believe, by estates and finance colleagues supported and signed off by boards, our view on the capital costs for the various different options. That's how that's been worked out.
Right, and they're pretty good at making the numbers add up, are they? They've got a good track record, haven't they?
These are based on fairly accepted norms of what it would cost to develop wards, etc., in terms of the building requirements that that the NHS has to work to. Is it an absolute exact science? The short answer to that question is no, because you do have to make some judgments on this, of course, but this isn't a whole bunch of people running off doing their own calculations which has no connection to each other, and therefore you can't base anything on this. But it's why we've said these are the best estimates at this point in time. If there were changes to some of the numbers or some of the requirements for buildings that were pertinent at the time when this actually happened, those figures may change, and that's why we're being cautious to not say these are absolute, but they're a guide to help in the decisions that over the next period will need to be taken on the scheme. And Joe might want to add in terms of some of the detail.
Yeah, I've really... Oh, my one's going red.
Oh, there you
go. So it's really, if it would help, I'll just tell you what Royal Surrey did. So we are one of the least impacted providers in this process as it happens, so we're not talking about a lot of beds. But what we did was to assess how many beds the activity that we would inherit under each of the three options would cause us to would pass over to us as opposed to the hospitals it currently does. We work with our estate and operations teams to work out how many beds that is and how much it would cost to put those beds on our site. We have a lot of knowledge about our site because we have extended that site regularly. And then we looked at what ancillary services would be required to service that activity. So as it happens, in Royal Surrey's case, we've just rebuilt that area. Do come down, it looks fantastic at the moment, it's brand new. We know that we don't have capacity for anything more than what we have in the next 5 years, so we actually have submitted a capital request of £2 million to extend that, to inherit the new activity under the sites that we would need. So it's quite a specific figure done by our estates, operations and finance colleagues, and I'm quite confident of it, if that helps.
say it's not an exact science, so what's the kind of margin for error that you would find acceptable, given that it's not an exact science?
I'm not sure I would know the answer to that question, and to guess would be the wrong thing to do. The reason I say it's not an exact science is there's a danger with these things that people say, well, it said £174 million in 2019 and it's now 186. What's gone wrong? It must all be. Well, these things move as time progresses, as we have more information, as I say, there might be changes to what we have to supply in terms of the building. So if the building regulations change, that says you need more space or you need different services to provide the care to the patients, that will change the capital costs. So they are accurate for the work that we've needed to do to this point, but I wouldn't want to stick with those numbers and say, well, that's all we're going to need, and therefore the bill will only be that explicitly, and book that now in 2019, because by the time that this process concludes, it's going to be a little while from now. We want to make sure that the costs were absolutely up to date at that point. But for the purposes of the analysis of the provider impact, on the basis that we've all used the same inputs to get this output, I think they're a helpful guide to this stage of the process. But that's not the same as saying this is the final cost that would need to be borne by the NHS on these options. That's something that would come as we get through the final stages of the business case process.
Well, can I just add, Chair, that the reason I'm asking these questions is that it's not so long since a number of us around this table were involved in the scrutiny of a misstatement in the accounts, a massive misstatement in the accounts, produced by finance team, overseen by the board. So that doesn't exactly provide me with the level of assurance that I think we should have. I think Councillor Fitzsimons may have been involved in that process and would remember it well.
Yes, that was London Croydon CCG.
Thank you.
Oh, PCT.
Yeah, please.
So I think. Okay. So these figures that will be. That's why we currently are not releasing all figures, because they're going through an assurance process through the regulators, so they will be tested. And we will have an assurance from the regulators that what we've assumed is correct. What I would say is that they won't be absolute numbers, but there is an ongoing process. There will be an outline business case and a full business case, and those figures will be absolutely agreed. But all of those things that Matthew spoke about, they would impact on all the providers. So the relative impact, when we're looking at an impact assessment, is probably going to be the same. And that's what we're using this for. We are using this to inform the business case, and the numbers will be, you got to an absolute correct point through the process, but what we're also using this for is to inform what's the relative impact on each of the providers. So it's not just about the money, it's also about some of the other things they've looked at, but the money is a good indication of the level of impact, because that's the level of beds and infrastructure costs that they have to put in.
Thank you very much. I think I just wanted to apologise. Bear with me 1 second. Councillor Critchard.
Thank you. Couple of questions. First one is, you talked about this has been dealt with through boards of all various trusts. Public paper or private paper? I've just scanned St George's, I can't see it in the public papers.
So the short answer, and I'll be straight with you, I don't know for every organisation, but I can tell you from Croydon's perspective, it was a paper taken in private at this stage, in advance of a publication of this work through the channels of the Improving Healthcare Together programme board, because otherwise we'd be having individual pieces coming out which don't actually connect together, which is what it needs to do to give assurance to the public scrutiny process. But I think it would be private everywhere, but I certainly know from my perspective it wasn't.
Okay, then this is a follow-on. From each of these options, now I've been sort of thinking, now it's all happening way down south, outside the M25, I don't need to worry about it. And then I look at this and go, whoops, if this happens, this is now marked as high impact for St George's. And that would be clearly worrying for many Wandsworth residents. Now, we've got the totals of what high impact means, but what we haven't got in this paper is any indication of what high, medium and low really means. So, you know, how many extra beds would it mean, how many extra staff? At this stage, can we have something about that, and also perhaps some financial breakdown? The total is given for the across the 6 hospitals. It's not given hospital by hospital. And actually, I would just say is that might be something that you might not wish to share publicly, but maybe that is something that the other board should be seeing, because you know it's made me worry.
So, colleagues might want to answer the question about what can and what can't be provided, but if I could give you some assurance around what these things mean, that might help a little. But I do appreciate, you know, saying there's a high impact on a provider that is providing your residents care clearly is going to cause some concerns, and we need to be aware of that. What the biggest impact for St George's, as I said, is similar to the impact for Croydon. It's if there is a major acute site at Epsom, because that means that patients who currently use St Helier would go to Epsom for their major acute care, but patients and the ambulance service would choose in some cases for those patients to go to St George's and Croydon as closer providers. So that's the biggest impact. That impact would be for major emergency medical patients largely, because that's the group affected. That's a subset of what both Croydon and St George's do, and the impact assessment that we've made is the relative impact that has compared to the other providers and the other options, whether that's St Helier or indeed Sutton. Because against the plethora of things that St George's do, of course this is going to have an impact, but is it the biggest percentage impact for St George's compared to everything else they do? The answer to that question is no. So it is a relative high impact, but in absolute terms, I'm not dismissing this as a non-issue, because as I said at the start, if I was in your shoes I could see why I would be concerned, but against the broad range of services that St George's provide, this is not the biggest element of it. Notwithstanding that, I understand your question, and I need colleagues to answer what we can and will release at what point, because it's all connected to what's in the business case, when it's gone through a regulatory process, what we can then provide more detail for, and I'll give colleagues to help clarify exactly when and what we will be able to do.
Right, I'd like to come back on this. This is a public paper, therefore this is in the public domain with something that says high impact. And anybody can read anything into that. And I would just say then is, you know, what do we now say? It now says high impact. Does it mean that A&E attendances at St George's would double under this circumstance? That's something perhaps you could take back as you put it in the paper, you've marked it down as high impact, but actually what does it really mean? Because what you're, I think, Mr Kershaw, what you're saying to me is, although it's quite high, actually it's a relatively small percentage of what George's already deal with. Yeah. But that doesn't come across at all in it. Yeah, that does not come across in this paper. And, you know, there might be someone from the papers going, whoa, what's going to happen next?
Councillor McKay.
Thank you, Chair. I mean, I'd like to just follow up on that point, because my personal experience is that my 4 children, 3 of my children were born in St George's, so that's my nearest hospital. My constituents, their nearest hospital is St Helier. I'm kind of interested in the weighting given to the hospitals that are closest and the impact that will be having on them. When I go to St George's Hospital right now, I find it, you know, the A&E department is bursting at the seams. difficult to, you wait many hours. That's my experience there. When I go to St Helier, as I have, with relatives, exactly the same. When I go to Epsom, when my grandchildren were all born, so I do know all three hospitals extremely well, exactly the same. Now, what I hear, what I think St George's, what I think Croydon are saying is that this is going to have an impact on them. And my sense is that already A&E departments are struggling to deal with what they already have, and yet it is proposed that there will be less A&E departments in the future. And really interested in Councillor Stranett's question earlier on, because when you were talking about finances, you were saying that beds is a key factor in terms of assessing the cost, and yet for some strange reason beds are missed off this paper and there isn't a reference to them, and I think his point was very well made. But my overall point is that we need more provision of A&E, not less, because it takes too long for most of us to be seen when we turn up at A&E and need the support of the NHS. And I think it's really important that we have the bed. And now, of course, we're going to hear the responses that you'll have 24/7, 365 consultant care. But I have to say, I've been a counsellor for 33 years, and I've heard people make promises in the past that this is what's going to happen when we reconfigure. And then a few years later, there are different people from the NHS sat around the table, and they don't seem to recognise the commitments that were given by their predecessors. So I'd like all of those questions addressed. But I think the biggest concern is that people are really concerned about A&E provision right now, and they don't want less, they want more.
Thank you, Councillor Kay. Please come.
So can I just take up?
Sorry, it's my fault.
Can I just pick up the point about A&E provision? So I'm going to tell you about Saturday at St Helier. So 78 people waited more than 4 hours on Saturday at St Helier. And they waited more than 4 hours to be treated because we didn't have sufficient staff. We needed 2 middle grade doctors when we only had 1. 2 nurses went off sick. And we had 73 ambulances. Down the road in Epsom, it was a very quiet day. And if we had managed to have the staff from Epsom working at St Helier, we would have treated just about everybody within 4 hours. And despite all our best efforts to recruit staff, we cannot recruit enough A&E staff to run 2 A&E departments that are 7 miles apart, 24 hours a day, 7 days a week, and have the standard of service that people expect. So it is really bad that a lot of people waited a long time. It's even worse that I couldn't vouch as the chief executive that they were completely safe while waiting for a very long time because we didn't have sufficient staff. So the provision that we need for A&E is that if you are really sick, you need to be able to go to any hospital in South West London or Surrey and be treated within a reasonable time by highly qualified staff. And with the current disposition of service that we have, it's not possible. The only hospital trust in South West London and Surrey that cannot meet the standards is us. And it is absolutely imperative that we get to a solution where, for the sick patients who we serve, and there's almost 500,000 people who use Epsom and St Helier Hospital as their local A&E, that we are able to give them really good care. And to do that, we have to get to a single acute site for the sick patients. And if you go back right to the beginning about why it's so difficult to do a timescale for all of this, the amount of capital we are asking for in this programme will be one of the biggest investments the NHS makes. It's £500 million to resolve the issues for Epsom and Surrey. It's a huge amount of money. I think when you read the stakeholder briefing that sadly not all of you have been able to do, you'll be able to see just how much work this programme has now done to make a really compelling case that the right thing to do is to get a new hospital in the catchment for Epsom and St Helier, and we are really close, I think, to getting through the assurance process successfully. I'd say when we asked our staff, do you support getting to a single acute site? 90-something% of the consultants said, yes, please, because we know that we'll be able to offer much better care for our patients when we do. So the provision is the right provision. It's not keeping the provision that we currently have in the way it's currently delivered.
Thank you, Councillor Stronick.
Sorry, Councillor, your case was asking about beds. So in the model that's in the business case, it maintains the same number of beds. In fact, there are a few more beds in the future than there are now. And when you look at the number of beds, you add up the number of beds for the patients in the Epsoms and Helier catchment. So if you take the Epsom option, for example, the reason where Epsom is the major acute site, the reason why Matthew has a high impact is because he needs to really provide, I think it's in excess of 100 beds. So when you add up the beds in all of the providers and the beds in Epsom and St Helier, in each of the options you end up with slightly more beds than we currently have. Because to do the bed modelling, we have done a really detailed piece of work which looks at, there are a number of factors which mean you need less beds. So, for example, to have a knee replacement today at the Orthopaedic Centre in Epsom, about 30% of people go home the following day. 5 years ago, that was a week's length of stay, because the operation is now done by a robot. It's now so precise that your pain levels are much less, so you need to be in hospital for less long. And there are lots of reasons why you can do things that require people to stay in hospital less time. Equally, we've got a growing and older population which has an increasing demand for beds. And when you put the two things together, where you end up with is the number of beds we need, we think, in 10 years' time is the same as we do now. And if you just go back 10 years of history, you'll see that the number of beds in Epsom and Helier hasn't really changed in the last 10 years, because the two things of shorter length of stay and longer length of stay have been pretty much cancelling each other out. What this programme is not saying, which is what has happened in the past, is you can magically reduce the number of beds that a health system needs by becoming super duper efficient. We know that isn't going to happen. So we have modelled, we think, accurately for what we think the population really need. So the bed numbers are slightly more.
Councillor Stronick.
I have to say, I'm beginning to feel a bit like a mushroom, kept in the dark, and I won't say what fed, but I'm looking at the Health Service Journal here that has published a report saying that a business case released on Monday talks about redevelopment of Sutton, redevelopment of St Helier, and Dagger, you're quoted in this press release. So we're being told we can't see a business case. It appears that the press are being given a different message.
So what the press have is what you guys, we hope to have had, which is the stakeholder briefing that the programme produced on Monday, which is on both websites.
So they've got it wrong when they say the business case. That's just
So the programme submitted a business case, and what Andrew and Sarah both said is we can't share the whole business case because it's what is being assured and it's full of technical numbers. But because the programme has no idea how long it's going to take to assure this business case, we all thought it would be much fairer to tell you in summary form what the business case said. So the stakeholder briefing is a condensed summary of the business case. And I don't think any other part of the NHS has ever been so open and transparent as this programme has now been, which is to produce a summary of a business case which is sitting with the regulators now for assurance. So perhaps I think the thing we should do is talk you through the stakeholder summary, because it's quite clear that some of you have read it and some of you haven't been able to. I think it would be
why was the stakeholder summary not included with this report?
Because the programme was only able to submit it on Monday. So
well, we didn't get an update. Sorry, I didn't get it. We didn't get an update saying, by the way, this is come out.
Yeah, please, Sarah.
So the focus of this meeting was supposed to be on the provider impact assessment, which is what we're trying to do. The unfortunate timing is that we were able to submit the business case on Monday, okay? And we made a statement and we have sent it around to stakeholders, and I apologise if you haven't got it, I really do. But we can send it around to you. We can make time, again, to talk about what's in there at a later date, absolutely. This is not going to, it's now with the regulators. There is time for us to have that discussion. Nobody has seen the business case apart from the regulators. So regardless of what the HSJ have said or Sutton Council have said, that is inaccurate. Nobody has seen the business case apart from the regulators and us. So it's not in the public domain. But what we have tried to do is put as much of the information that we are using into the public domain. So we have opened a website for Improving Healthcare Together, and on there you can find the evidence that we have used to put into that case. So you'll find the impact assessments, you'll find information on inequalities, you will find, what else have we got on there? Not all of the money, but some of the money. You'll find the stakeholder briefing, you will find quite a lot of information.
It would appear that there's a recommendation.
So there is a ranking of the options, which is in the business case, which we put in the public domain. The reason we've done that is we haven't, as I said, we haven't made a decision. We haven't made a recommendation around a preferred option, and we've told the regulators that, but we were required as part of the business case process to rank the options. And the ranking is out there, and the ranking is Sutton, and then St Helier, and then Epsom. That is the ranking that's currently in the business case. That is in the public domain. That does not mean that that is our recommended option, because we haven't been through that process, and things may change if we get additional information or we change assumptions around the finance. We've been accused of being secretive. We have tried to give you information. Normally people would not make this information public until they actually set out a pre-consultation business case, go to consultation, and then it all becomes public at once. We've decided that we'll put a lot of this information in the public domain because we don't want to be accused of trying to keep it secret. That's difficult because then you get bits of information coming out over a period. And you won't get it all at once, because actually what we try to do is give you the information as it becomes available, rather than just holding on to it and then coming out with a big thing at the end of it. And I mean, that's a judgment on our part, but what we decided to do was it was better to get that out into the public domain than it was to just keep it and then release it all at once. That was our view. And hopefully people will appreciate that we have done that. And as we've said before, once we get to the stage where we are going to go into consultation and we're going to do that formally, we will release all of the information at that point.
Thank you, Sarah. Councillor McCabe?
Chair, I just want to make the point that councillors, people sitting around this table, receive confidential information on a regular basis. It's on green paper in Merton. I think it's probably the same in whatever the colour. But the reality is that, and this was raised at the job shop, I believe, what was said was if you're going to make this on Monday, then get it in the agenda, get it out with the papers on a confidential basis, share it with people. We deal with confidential matters all the time, and that's the way to do it. And if you want to be open and transparent and you don't want us to be accusing you of being secretive and lacking in transparency, do that.
Thank you, Councillor. I think I just want to add that point that as JOS Chair, I'm obviously extremely happy to liaise with the officer and field out information that could be late material or as we see fit, can be deemed confidential. I'm very happy to do that.
So that's very helpful, because we've been asked in the past not to send late papers. So we are happy to do that as long as you're happy, Chair, to accept those.
Well, I think it'd be better to be as informed as possible, and even if it is deemed late material, I do think it would be in everybody's interest, if everybody's in agreement, to proceed on that basis. I'd be very happy to submit something, but not as the norm, but just in the situation what we just had, that it would have been beneficial.
Can we also, we will make sure everyone's got the link and has got the information after this meeting, so we'll make sure we've got the contact details. So if we send them to Stella, if that's okay, we'll make sure that's sent out immediately after the meeting. Oh, there we go, we've got some hard copies as well.
And Councillor McCabe?
Chair, just one other thing. I think Daniel spoke with great passion about what happened on Saturday night, but for it to be meaningful in any way. We need to know what was happening at George's, what was happening at Croydon on the same night. And I have to say that the impression that was created is that Epsom was empty and that St Helier was crammed. I always hesitate to raise issues, personal issues concerning members of my family. But there was a member of my family aged 92 who spent many hours in Epsom Hospital on the nights before you were talking about, and you know he's had a stroke. I don't think there's much from that experience of our family that suggests that Epsom is you just walk in there and you're treated straight away.
So what I was just trying to make the example of is if we managed to get the workforce in Epsom and the workforce at St Helier for A&E in one site, in this example doesn't matter whether it was Epsom or St Helier or Sutton, just having the workforce in one place would have meant that we could have treated the patients much more quickly and much more safely, because they were very busy in one place and not so very busy in the other. So we didn't make the best use of the manpower that we had. And given that we're not able to increase the amount of manpower that we have got, no matter how hard we have tried, then actually the answer has to be to put the manpower in one place, not try and perpetuate two sets of services that are not clinically sustainable.
Thank you, Sarah.
Can I just make a point on clinical standards? So about a year and a half ago, the medical directors across South West London, so the medical directors of the acute hospitals across South West London, came together and set out some standards of care for patients that they believe need to be achieved in order to meet national requirements, in order to meet best practice for rural colleges, and they set out the clinical standards. The only trust in South West London that cannot meet those clinical standards around A&E is Epsom St Helier. And so what we believe is that they are not received, so people who attend those sites will not be able to achieve the same level of care as the other sites in South West London. All of the other trusts through their boards, and they all believe that they can meet those standards. So it was only Epsom St Helier, because of the two sites, that believes that they can't meet those standards, and that was something that was brought together as best practice. It was quality standards based on national advice, and it was led by the medical director of South West London.
Thank you, Sarah. Are there any questions? What I'd like to do then is, I'd like to I have been making a few notes. I just want to perhaps capture some of the comments that have been made this evening and just produce a summary of points, just to see if that's helpful for members and yourself. So what I just want to just say is, I think I've picked up on a comms issue at the beginning that Councillor McCabe was and Councillor Steers were mentioning about, that perhaps, and we've looked at perhaps a mechanism where we can draw from all of the assessments and impact assessments and so on. There are an awful lot of anachronisms and documents that perhaps, as you say, they're in one place. It'd be easy to look at them to be better informed. But I think also, in terms of timing for subcommittee, I think just to make a note that that obviously when papers are released, if they can be given to members as soon as possible. I think also for me, making my notes, I think sometimes when you're very close to a project or a programme, I think even a simple timeline or table, it actually is so beneficial, where you can actually give, like any project plan, you can have your timeline and you can say what your key deliverables are, and perhaps what some of the key challenges are going to be in that timeline. I think that's always very helpful, and I think something like that, as you go forward, perhaps if you can consider giving us something along those lines. I'm sure when Councillor Steers and Councillor McCabe communicate with you on the subcommittee issues, but that would, I think, moving forward, that would be very helpful. I also think as well, looking at stakeholder feedback, I mean, I'm very conscious that there's a key challenge you're in pre-consultation, so I think moving forward, Councillor McCabe made a very valid point about at local level, what does that mean to your stakeholders? And I think as that feedback filters through, I'm sure that's going to influence your decision making in that process. So actually being able to take that feedback and say how has that influenced your decision, I think would be key. I also think looking at key challenges, I think Daniel mentioning impact and assurance process springs to mind, because obviously you're waiting for regulators to come back. So I think we're in a, not limbo is probably not the right word, but you're in a stage where you're waiting to get regulator feedback. But certainly I think from timing perspective and when the stakeholder feedback and when assuming that you can move forward with consultation, I think again that will be key. To know what the impacts are, whether they change through stakeholder feedback is what I was trying to say. Again, financial assumptions. My question really was to ask whether whether you're still gathering evidence of financial nature, whether that's actually been submitted, or could that be likely to change? That was my only question in that process. But that really was the sort of summary of points, I think. If I've missed anything, please let me know.
So it can be subject to the change to financial, which is one of the reasons why we haven't submitted it into the public, because we won't, the regulators, and this has happened in other areas where the regulators have said change the assumptions because we can't support that assumption or whatever. So we haven't got a lot of more evidence to gather locally, but we may well have to change our assumptions based on what regulators tell us. So that's a good change. So we will let you know if that happens. But actually, that's one of the reasons why we haven't put it all out in the public domain, because hopefully by the time we get to the final one, that will be more solid. Although there is an ongoing process, as we talked about, around times changing, outline business case, full business case. So those processes will change. Can I just ask a question? So we're really happy to, because remembering that this is a full JOSC and we've been working with the subgroup, it sounded like the intent is from now on to be a full JOSC process, and that we're not going to have the subgroup, or are we increasing the sub? So what I'm a bit unclear on is that going forward, if somebody could just clarify that for me. And the second bit was all of the information that you talked about, a lot of that is on the website. I think what we should do after the meeting is, because I think a lot of people some people have seen it, depending on how close you are to it, is send you out the link to the website and all the documentation, so that all members of this committee have all of it, along with the most recent update, which we'll send separately to you. And then we're happy to take questions from anybody, to be honest, at any point. It doesn't have to wait for a JOSC meeting. We are happy to receive questions and to respond to those through the programme. But can I just ask a question on the committee?
Yes, because I think we were going to actually come to that point. And I think if I perhaps just ask Stella just to say a few words at this stage on the process tonight.
My understanding is that it's for the committee now to determine if they wish to expand the subcommittee. They're still separate entities. The main JOSC still exists as it is, and the subcommittee will determine, and the JOSC will decide whether the subcommittee expands its membership for those interested authorities.
Just that we would be happy to report to whichever OSC is the right one, but what we don't want to do is end up with two JOSCs.
No, you can't. I mean, according to the scrutiny guidance, we can't have two JOSCs. Exactly. There can only be one. So the two entities will remain, and the subcommittee will continue in its work in scrutinising the programme.
We've had a discussion. I think we recognise that the provider impact. We recognise the provider impact assessment, and it's been set out here, does have an effect. And the full JOSC has two representatives from each borough. I mean, that would be far too big for the subcommittee. So what we're proposing is that a small increase in the number will greatly reflect the opportunity of all the boroughs in South West London to actually become part of the subcommittee.
Correct. So you're going to have full JOSC with every borough on, and then you're going to have sub-JOSC with all the boroughs on.
Is that what you agree?
that was a discussion. The other thing is the just will meet, the subcommittee will meet far more regularly. We can have a discussion, but what we've got to do is make a decision tonight if the subcommittee is going to expand. It would be another four boroughs.
Yes, indeed. I mean,
Well, so is there anyway.
yeah. I mean, may I just quickly add, and then I'll just let my comment was more about just Joss just having more of a comms issue about wanting to have as much information to hand as on the night. This issue is about representation of the subcommittee. I think that's what we as members had discussed for tonight.
I'm just checking if you're replicating the Joss at a subcommittee level. Is that what we're? And then are we going to report to both, or just I'm totally confused? Sorry.
I mean, we've had this discussion beforehand. I think the issue for us, or for me in particular, is that this Joss needs to look at the issue of the South West London and give that much more time. So having a subcommittee would allow that one subcommittee of 7 people or 8 people to concentrate on that one particular issue, while allowing Joss to carry on its role as the Joss for South West London, because there's lots of other things that are going on at the moment, which at the moment we're not discussing.
Yes, please, Daniel.
So if you were technically going to reflect the boroughs relative to Epsom's and Hellier's catchment as a district hospital, then the boroughs we've got on the subcommittee are correct. And then you would need the borough of Kingston, because there is the little place of Morden, Rushington, Chessington in your borough, which use Epsom currently as a district hospital. And you would need Croydon, because there is a tiny bit of Croydon that uses either St Helier or Epsom. But Epsom St Helier is not a district hospital for anybody in Wandsworth or anyone in Richmond. Because I get you look at the impact on other providers, but if you wanted to, if you technically wanted to expand the subcommittee to cover the current catchment of Epsom St Helier, you need 2 more CCGs, and clearly if you wanted to cover all of the provider impact of all the different options, you need everybody. I just thought it might be helpful.
Thank you, Danny. I mean, my understanding, so please, Sarah, correct me if I'm wrong, but my understanding is it was based on individual members who want to actually, it's opened up to the idea that an individual member here sitting this evening who wanted to expand membership of the subcommittee, which is the decision-making committee for this particular programme. My understanding is that's something that we could agree tonight as to whether there are, and that depends on individual members here this evening.
So I can only say that just to point out that Richmond, I believe, are not represented here this evening. No, sorry, already on the DOS.
Oh, yeah, on their subcommittee.
Yeah, on the subcommittee. So it's whether other boroughs, I think maybe we should take it borough by borough if they want to decide if they want to join.
Sorry, I think the problem is that we can't expand the Joss to include Surrey. Right? No, but I mean, they're on the subcommittee. And yes, but I mean, it'd be...
Surrey Downs are on the subcommittee because there's 33%. They're 33%. There are 3 other areas that have a 1% catchment area. If we look at the old 17-18 data, that's why I'm saying it'd be great to have some more up-to-date data. It might change, I don't know, but Daniel will be closer to that than any of us. But I think if you've got a 1%, which I think is, if I remember rightly, Richmond, Northwest Surrey, and some, there's 3 areas at 1%. I wouldn't see that as materially needing to be represented on this committee. I do think, though, with all the evidence we've heard about the provider impact assessment, and we haven't got a recommendation yet, we need to make certain that looking forward, once that comes out, our committee the subcommittee is actually in a position to move quickly forward. We don't want to have to come back here and make another decision to increase that. So what we're trying to say is, by expanding it to the South West London boroughs, Kingston, Croydon and Wandsworth, what we're doing is preempting and trying to have in position, once the regulator makes that decision and you go to formal consultation, on the basis of the provider impact work as well, that's what we need. So we're trying to sort of preempt what might be happening, so we don't have to come back and have another meeting to set it up. So that's what we're trying to do.
Thank you, Councillor Steers. I think what I'd like to do is, I mean, I can only. Sorry, I didn't mean to.
No, so I was present for the first session we had when we were looking at in fact we had a rerun. I think we're engaged in rerunning the discussion that we had, I think, at the first session when I think the subcommittee terms of reference was being discussed and worked through. And I just want to just recall, I think the discussion is consistent with that, in that the subcommittee reserved its position to extend the membership to the appropriate boroughs to discuss items which were on a wider basis. And I think what I'm hearing Councillor Steers say is the intention is not to replicate this committee, but that where it is appropriate to extend the membership to discuss wider issues, that the subcommittee would allow on an optional basis those boroughs to join that subcommittee meeting. That's my understanding.
That is correct, because I'm looking at my fellow colleague, Councillor Abraham, and I mean, it's clear to us that Kingston is quite. Sorry, excuse me, Councillor Fitz, I'm just trying to say this valid point that Kingston at this stage, we may make the decision that it's not as yet required for us to join the subcommittee, but that's not to say that they wouldn't be open for us at a later stage. So I would like to just, if it's helpful, just to see a show of hands of those members here tonight who would like to join the subcommittee. I think that might not be a bad way of going about things, just have an initial indication would be helpful.
Sorry, we're going to have a potential meeting in September, right? Then we would need to have people agree tonight so that they can be formally invited as per the meeting.
Councillor Steers, have you got any further ideas?
Do we have to nominate an individual, or can we say a representative that sits on the JOSC from Croydon, from Kingston? There is a place for them, because it strikes me as a much more, we don't want to have to tie ourselves down. What we want to do is give people the opportunity to come along. So if there's two of you from Croydon, one of you sits, let's not give ourselves too much of a problem.
And the 26th of September is the date that we have in the diary for the next IHT chance.
26th of September, I've got.
So it's already set up. So when I said we were bringing it in September, that's because we already have a date set up. It wasn't that we were asking you to put a new date in.
And I was listening, and you were saying you might have something to come to that September meeting about timelines, etc.
Exactly.
So actually, I think it's really important that all the South West London boroughs are represented. We all need to hear that your before the official thing comes out, we all really need to hear what that timeline is going to be for all our residents.
If that's, I'm sensing that is an agreeable way forward. So, Stella, if that's a recommendation that I can make, or we're going to say the wording of that this evening.
You want to propose a second?
Well, no, if you all agree, then you don't need to vote.
Yeah.
Yeah, okay. I mean, it's subject to agreement from Richmond, so I assume.
I take that then that's a consensus that's how it's a consensus that's how we'd like to move forward with the subcommittee membership. I see a show of hands to say that, please. Okay, I think that's gone through. Thank you very much. So on that basis, thank you very much indeed for you all who've come this evening. And I conclude the meeting at 5. Oh, I do apologise, Councillor Stanek.
We talked in the pre-meeting about the merger of the CCGs into South West, and there's a plan that has to go up to NHS regulators by the end of September. Is that right?
Yeah, so we did speak to the chair of JOSC, and I think everyone is clear. This is not we don't have to consult on this. It's not an area of service change at all. It's structural change. But what we would like to do is come and talk to the individual. We tried to set up a meeting of the chairs of the JOSCs to try and have that discussion, but it didn't happen, and lots of people called off at the last minute, and we ended up with 1 or 2 people around. So I've asked all of my teams to contact the chairs of the JOSC to sit down with them and to talk them through this, so that each individual JOSC each individual OSC has a briefing on where we are and what we're doing and how we work with the OSC and the Health and Wellbeing Boards going forward. So that is the plan. So I'm hoping someone is contacting you, and if they aren't, I'm happy to come myself.
Well, I welcome that, but like my colleague, we've got a JOSC here, and decision making is being that potentially the new one CCG 10, 15, 20% of items are going to be decided at that level rather than at a local level.
The South West London proposal is that we have full delegation now. That's
100%.
Yeah.
Okay, that's the first I've heard. That's 100%. I think we need a second.
So I think you need to have the individual discussions with each of the borough leads, because it's not. We have discussed it with the chair. It's not actually a decision that we will be consulting on, so it's not something that's a significant change to service. But we want to keep you as up to date as we possibly can on what we're doing. And it is moving, because we are having discussions with our membership. It's a membership decision from our GP practices. But we would love to come and talk to you individually, and we actually have people ready to come and chat with you from each of the boroughs. That was the agreement that we had with the chair of JOSC and Home Tax Form.
Thank you, Sarah. I am mindful that I want to, this has not been an official agenda item. That's not to say we can't discuss this, but I would like to take this offline. And I think, Councillor Fitzsimons, if there are any further questions you have on the specifics, I think it'd be useful to have an offline conversation with Sarah after this meeting and her colleagues. But I would like to conclude, if I may, on the agenda items that have been discussed tonight. If there are no further questions on that specific item, I'd like to conclude the meeting and it's now 9:10. So thank you very much indeed, everybody. Thank you.